Now this is a very important segment. In pregnant individuals, and all pregnant women should be tested for diabetes, at least in our country. The glucose tolerance test is done in a different way. You collect samples in the fasting state, in the state of having a glucose administration after 1 hour and 2 hours. If the fasting plasma glucose is more than 92, 1 hour value is more than 180, and 2 hour value is more than 153, and any one of these values is exceeded, then you say that the person is having diabetes. These values are very important and very sacrosanct. They are different from non-pregnant individuals, but they need to be remembered because they apply to a large set of population, and unless we know when to diagnose somebody with gestational diabetes, it will be very difficult to treat them. So we are talking about numbers, and we got this one number that we have to consider for the diagnostic cutoffs, either by way of a fasting plasma glucose, or after a glucose load, or after HbA1c, and in pregnancy the gestational diabetes of the type and kind that we understand, which is due to the pregnancy, one has to do a glucose tolerance test at 24 to 28 weeks, and if these numbers of 92, 180 and 153 at 0, 1 and 2 hours are exceeded, any one of them, then we say that somebody is having gestational diabetes mellitus. So fine, you diagnose someone as diabetic, but there are other people who are not aware that they have this disease. So who are the people who need to be screened for diabetes? So we have people who are at risk. We were talking about gestational diabetic woman. So a woman who has had gestational diabetes, that is, she had high plasma glucose values during pregnancy, delivers. She is at risk for developing diabetes. If that woman was not tested and she has had given birth to a macroscomic baby, a large 48 babies, then that woman is at risk. People who are obese, people who have got family history of diabetes, people who have hypertension, people who have got dyslipidemia, that means abnormal concentrations of the fat content in the body, people who have got polycystic ovarian disease, all these individuals also are at risk. So more the number of risk factors you have, the greater is the likelihood of you having diabetes. When do we test? So obviously you can't test everybody, and age is an important risk factor for development of diabetes. So people say that in the Western world, people consider screening for diabetes at the age of 40 or 45. Many people feel that this should be screened earlier and earlier in our country, given that we get diabetes about 10 years earlier compared to our Western counterparts. So people who are at risk need to be tested, and the age cutoff for at least adults seems to be at least conservatively 40. In children, if you have got also these parameters, then you can test them at an earlier age. Some people say that testing is required at about age of 14 or 15. Having said all that, if you are not testing for asymptomatic disease, you will not know who is diabetic or not. So there should be greater impetus on testing for diabetes. And one parameter which I forgot to discuss was if somebody has shown a derangement in the glucose in the past, what we call pre-diabetes. See, we said the fasting plasma glucose, again we are coming to numbers, should be generally less than 100. The post-glucose values should be less than 140. In diabetics, we told you that the number should be 126 or more in the fasting, and more than 200 in the post-glucose state 2 hours after the glucose load. If the numbers are intermediate, let's say that you have a number between 100 to 125, or you have a number between 140 to 199, then these individuals are not normal. They are not diabetic either. We used to call them impaired fasting glucose, that is, they are higher than the normal fasting plasma glucose, or an impaired glucose tolerance when they had higher than the expected ranges after 2 hour glucose, and now it is called pre-diabetes. So anybody who has had pre-diabetes also is at risk for developing diabetes in future. So this is something about people who are at risk. So many people think that if you do not have excessive urination, excessive thirst, weight loss, as we had discussed about the symptomatic diabetics, then you do not have diabetes. It is true that when somebody's plasma glucose levels are very high or they are very much insulin deficient, as happens in type 1 diabetics, then they are symptomatic. But more number of people with diabetes are asymptomatic. So lack of symptoms of the type and kind that we have just discussed does not mean that somebody is not suffering from diabetes. Diabetes is a disease which can be diagnosed only when you have got elevation of plasma glucose beyond the ranges that we have discussed many times over earlier. So it is important to know what the numbers are. It's also important to know whom to screen. And once you have diagnosed people with diabetes, then it is important that they be treated. The diagnosis of diabetes often comes as a surprise because many people are asymptomatic. There is a huge spectrum from asymptomatic people to people presenting with complication of diabetes and asymptomatic people. One tends to see these people being diagnosed when they are, say, going abroad for a visit, or wanting to take a life insurance policy, or just having a casual test done at home when other relatives are being tested. So it is important to know that most of the people with diabetes are going to be asymptomatic, and if one has to then treat these people, one has to diagnose them. Now, why should we diagnose diabetes? If diabetes is treated early enough, and if it's treated nicely without having any low sugar reactions, which we will talk about a little bit later, then the likelihood that these people will get complications referable to diabetes, largely in terms of damage to the eyes, kidneys or nerves, is going to be prevented or postponed. So it is the complications that are inherent to diabetes which are going to be prevented or postponed. There are other complications which are referable to the cardiovascular system in terms of a premature development of a heart attack, what is called myocardial infarction, or a stroke, or peripheral vascular disease, that means which involves diminishing supply to the foot vessels. But these can be problems which can be exaggerated in a diabetic. It's not that non-diabetic people don't get this complication, but the complication that we were talking about earlier, specific to diabetes in terms of eye involvement, kidney involvement, and to some extent nerve involvement, are on account of blood glucose level, which is the driving factor, and these are called the microvascular complications. The other complications that we talked about are the macrovascular complications, which are not unique to diabetics, but they occur earlier, they are more extensive, and they are, for pregnancy, it is also the most important parameter. Now, when we are choosing drugs for controlling glucose, one must differentiate between drugs that produce a low sugar reaction inherently, which is insulin, versus drugs that do not produce a low sugar reaction. Why do we say that? Because if the drugs which are producing hypoglycemia is something that can always happen, and that's going to temper the target or the aggressiveness with which one is pursuing the goal of normalizing the patient's blood sugar. So you have therapies which do not cause hypoglycemia, and in them you have metformin. These drugs do not inherently produce hypoglycemia, and if these are the only agents being used alone or in combination, then your HbA1c target can be anything. It can be 6.5, it can be 6. Mind you, we are diagnosing this condition at HbA1c of 6.5. So if these agents are being used, you can have HbA1c target of 6.5 or less. The normal HbA1c is 5.7. You're talking about pre-diabetes. Pre-diabetes, we told you about the blood sugar number. So if somebody's HbA1c is 5.7 to 6.5, that person is called pre-diabetic. So if you want to lower the plasma glucose and you are treating the patients well without any hypoglycemic agent on board, then you can lower to whichever extent you want to. If, however, you are using drugs which produce hypoglycemia, you have to factor in many conditions. The most important thing is the patient having good support system? Is he living alone? Does he have previous hypoglycemic episodes? Does he have cardiovascular disease? Does he have renal impairment? And all these things will be factored in if you have got a hypoglycemia producing drug in place. If you do not have that, then I think you can choose any target. The second thing is that lately, in the past 3 years or so, there is evidence now to say that certain drugs do benefit the heart. So if somebody has got atherosclerotic cardiovascular disease, heart failure or renal failure, these drugs have been known to be protective in populations who have had prior cardiovascular disease. In people who have got renal impairment, also SGLT inhibitors are known to produce a reduction in the hard endpoints that you have in terms of doubling of serum creatinine, need for renal replacement therapy, progression of proteinuria, and prevention of the renal death, that is death occurring in patients with renal failure when there is no other cause like the cardiovascular disease, which also occurs very frequently in those individuals. So if you have got these, then there is an indication to use these agents preferentially over and above the other agents after metformin. We did not mention this in the beginning, but metformin is the cornerstone of initiating anybody on the anti-hyperglycemic therapies, and we stratify people based on their HbA1c and based on our target. A given drug may produce HbA1c lowering by at the most 1 to 1.5%, but if your target is let's say 7 and your HbA1c is 8.5, there is no point giving metformin monotherapy, though it's a very good drug, it's cost effective, it is very easily available, it does not have many side effects, does not cause hypoglycemia, does not cause weight gain, may actually produce weight loss in some individuals, not in all individuals. So you have a person whose HbA1c is more than 8.5. There is no point giving just one drug. You might combine 2 drugs with complementary mechanism of action so that this person gets to target. There is enough evidence based on the findings of the UKPDS study that early, intensive, aggressive lowering of glucose to the target that you have produces benefit in terms of preventing or postponing the development of not just microvascular complication, but if given for long enough, even macrovascular disease, and also preventing mortality.